Disparities Impact Statement. And I'm Kathy Lazier, the co-director of the Cultural Linguistic Competency Hub of the TA Network at the University of South Florida and the Center for Community Learning. And I'll be one of your presenters today. I'm joined by Dr. Peter Gamache of Turnaround Achievement Network, who is leading the System of Care Technical Assistance effort on the Disparity Impact Statements for the TA Network. Before we begin, we'd also like to thank Dr. Cosima Boston, the project director for the Florida System of Care Expansion, who many of you know, whose vision of a cultural and linguistic competent system of care in Florida is the motivation behind a number of the initiatives focused on eliminating disparities in Florida's child, youth, and family serving systems. Dr. Boston will be available for questions following this presentation on this call about the Florida expansion. It is our hope that after today's webinar, you will have a better understanding of the reasons behind SAMHSA's requirements for a behavioral health disparities impact statement. And it's important in the work that you do. Another thing this webinar should also help you with is to convince others possibly who may be in positions of resource allocation that targeted specific resources need to be available that are focused on addressing unequal access, use, and outcomes in behavioral health care. Another objective is to discuss how to create a disparity impact statement, including how to gather and interpret disparities data. And finally, we want to explore how to create organizational changes to address the disparities you identified and address them through your planning and provision of services. We will share examples and lessons learned from other grantees. We will also have available and send you in a separate email some examples of impact statements following this presentation. For example, Miami Faces has a very good disparity impact statement that they have generously shared with the TA network for distribution, and we can make that available to you as well. So while Florida's System of Care expansion includes 5 regional sites, the expansion is an exciting opportunity for all of Florida's counties to plan and implement services and supports that are organized into a coordinated network that builds meaningful partnerships with families and youth, and also addresses their cultural and linguistic needs in order to help them to function better at home, in school, in the community, and throughout life. A basic premise of community and organization-focused cultural and linguistic competence is the importance of systems of care developing a population of focus. And you'll hear that term over and over when you're working within the grant communities or when your project officer comes down, like who is your population of focus? And that is just about being clear about the children, youth, and families for whom a system of care exists and serves. Sheila Pyries, author of the Building Systems of Care Primer, who many of you may have met at the All Florida meeting last week, states that system builders must be thoughtful about the characteristics, strengths, and needs of subpopulations within the population of focus, so that relevant strategies will be pursued and responsive structures built. So that really is the foundation for the need for the disparity statement. Let's talk a little bit about what we mean by this as well. The demographics of Florida have changed, and they're ever changing. Florida's rich diversity is part of its beauty, but it also offers challenges. With this increasingly diverse population comes an increasing need to meet the challenge of eliminating disparities and disproportionalities. So that we are all on the same page and working from a common framework and a common platform, we define disparity as an inequality marked by a comparative difference. And that is the difference in outcomes and conditions that exist among specific groups due to unequal treatment or services. So for example, research has shown that racial and ethnic minorities, populations who are more likely to be poor, have lower educational levels, or both, are fundamentally at a greater risk of ill health than their non-minority, non-poor, better educated peers. When we talk about disproportionality, we're talking about a skewed representation of a given population group. So that is the over or underrepresentation of a particular race or cultural group in a program or in a system compared to that representation in the general population. So for example, LGBT youth are overrepresented in out-of-home care and in homelessness. Or another example is, while Black children make up 18% of preschool enrollment, close to half of all preschool children who are suspended more than once are African American. That's the difference between the disparity, which is the comparative difference, and the disproportionality, which is the skewed representation. So let's take a look at how much of an understanding you have around this. So keeping these definitions and examples in mind, would racial and ethnic minorities endure higher rates of morbidity and mortality than non-minorities be a disparity or a disproportionality? Okay, if you said disparity, you would be right, because it's an inequality marked by comparative difference. Let's try another one. Disparity or disproportionality. Racial and ethnic minorities experience greater challenges accessing behavioral health services compared to non-minorities. Disparity or disproportionality? And again, if you said disparity, you're correct. It's an inequality marked by comparative difference. And the last one we want to take a look at is this example. The local detention center confines a higher number of African American and Latino youth compared to the racial ethnic makeup of the county. Disparity or disproportionality? If you said disproportionality, you are right. Because again, it's a skewed representation of a given population group here. You can see Peter included this graphic in here, really a visual. And visuals can be very powerful. You can see how the 15% is a very small slice of the pie compared to the racial and ethnic makeup of the county. You can see how there is this disproportionality. And we can talk some more about this at the end as well. So go ahead and. So you can see here that the demographic trends, they're not only going to be interesting, as you're going to see, but it's also the data that we need to plan for effective services. So I'm now going to turn it over to Dr. Peter Gamache to take us through the demographic trends and then also the development and using of the behavioral health disparity impact statement. Peter?
Thanks, Kathy, and thank you everyone for joining today. This is definitely exciting for us to connect today about this important topic, and having a behavioral health disparities impact statement, it's thrilling because it's a real opportunity now for systems of care and SAMHSA-funded projects to address the quality services that are needed to reduce and eliminate racial, ethnic, gender, and LGBT disparities. So this is just a wonderful conduit and opportunity now that's been put in place administratively and structurally. So we're just very excited for this because this has been many years in the making. And so when we talk about, why is this needed and what's going on here, Kathy had discussed the changing demographics and the changing diversity proportions that are within certain states across the United States. So, we are definitely an ever-changing country with people who are migrating and different population groups who are being seen and more each day, and the visibility of these groups is increasing. And part of this is that we have great data that now shows this. This is not just a conceptual sort of, thing about, we have great diversity within Florida and across the United States. Well, we've got some great census data and really powerful objective sources of information that can be pointed to show that there's a real need to address disparities and disproportionalities. And one of the major changing points was that in the year 2000, the U.S. Census, which is the decennial census every 10 years that it's conducted, in the year 2000, it was the first time ever that there was a question for people to be able to respond that they were multiracial. And it's kind of amazing that that hadn't happened before that year. And the U.S. Census has been evolving for I mean, since it was created, one of the first U.S. censuses that was distributed, there were really only two racial categories. It was white and black. And so now we have many different, questions and ways that the population of the United States is being better understood in terms of its diversity. And then in 2010, just about 5 years ago, was the first time ever that there was a question on same-sex households. And so before then, we didn't have really any data other than some surveys that had been done, some national surveys, but in limited form. But now the U.S. Census has these as core questions. So this is really showing how, that this is something that's definitely changing. And when you look at it visually, it's very striking. Here's a map that's available based on the U.S. Census data from the 2010 census, showing the two or more races distribution across the United States. And you can see there's some areas more than others, but this is a pretty green map in terms of the representation of two or more races in different areas. And then if you look at, I know some of these numbers are a little bit small because they're in list form, but if we look at some of the numbers and compare them, so on the left-hand side we have the regions overall, and then we have the specific states that are listed, and then we have the column for the year 2000 and then the year 2010. And if we look across, so if we look at Florida about halfway down, we can see 376,000 people approximately versus 472,000 people, and these percentages as a proportion of the population are definitely increasing. And the very far right-hand corner is the percentage change that's calculated from 2000 to 2010. So just in one decade, you can see these very large numbers, rolling down in terms of the percentage change. And this is even in some areas that you wouldn't even think, across the United States, demographic patterns are changing very, very quickly. And part of the contribution of this is that we have a definite intermarriage trend that's been happening. And if you look at some data, this is from the Pew Research Center, and relatively recently, just about 30 years of a comparison here between 1980 on the left side versus 2010. Just in 30 years, the intermarriage trend you can see has increased more than double, really, between where the percentage of marriages involving spouses of a different race or ethnicity from each other has increased in such a small amount of time, or a relatively small amount of time, really a generation. And part of this is from 1967, the Loving versus Virginia Supreme Court decision declared that it was unconstitutional that the races could not marry one another. And so this was something that had already begun, and had been part of, having these state laws that were being struck down on a state-by-state basis. And then the Supreme Court stepped in and said, okay, now we're just going to finalize this and make it so that it's completely unconstitutional across the board. And so we're seeing these trends now between, for intermarriage, and part of that is this, the structures that are supporting that. And attitudinally, it's also important to consider, from just 1985, and here's another chart here from the Pew Research Center, from 1985 to 2010, you can see that the percent change of people agreeing that with the statement that it's all right for blacks and whites to date each other, pretty much almost, it just hugely rocketed upward from 48% to 83% in just that short amount of time. And then what we hear a lot, especially working in systems of care with youth, is that really the trend on these, the change in attitudes are being driven by the youth. So if you look at this this graph or this line chart on the right, you can see that the support of interracial marriage is very different if you look down from the 65 plus age group versus that 18 to 19 age group. So among youth, there's wide acceptance. It's not abnormal or different or strange, or it's not how they grew up. This is just a very normal thing for youth. And so you can kind of see the trends, and it's interesting to see, the higher you go with the age groups and where these perceptions are changing just by age demographics. It's very interesting. And then similarly, also for same-sex marriages, we have polls from the Pew Research Center that show people opposing versus favoring gays and lesbians to marry legally. And just from 2001 to 2014, just in the span of 13 years, we've got this crossover change where the acceptance has really outpaced the opposition to this. So attitudinally, things are moving, and the acceptance of diversity and inclusion is definitely on the trend. And again, if we look similarly by age, it's interesting to see the differences from the millennials at the top and Generation X, and how accepting and the perceptions are among that group versus the older generations. Very interesting trends that we're seeing. And it's also important to reflect on the changing ethnicity in the United States. This is a nice map from the Georgetown Public Policy Review showing the Hispanic population by congressional district. And so you can see that there's definitely clusters and densities, but this map over time is becoming more colorful and spreading across the United States. And we have, as I mentioned, the 2010 data for same-sex households that were crunched by the Williams Institute in California. They took all the data and made really nice maps and everything, and you can see this sort of United States spread map at the very top here that specifically looks at same-sex couples raising children, and you can see that it's spread out across the United States. And in some areas that I've worked with very closely, where you maybe wouldn't think that people, would be that very prevalent in a certain state, for example, in the Southeast or, some areas where the sort of, political climate is different than it is in other areas. You can see there are still areas where there's a wide spread of people, for example, in Mississippi, there was a remark that they lead the nation in the percentage of same-sex parents. And that was a real striking, oh, wow, that's interesting, because you wouldn't think, Mississippi, but yeah, that's exactly how that's shaping up. And I'm working with Partner Systems of Care in Mississippi, and they're doing incredible work there. So it's interesting to see, the data. And it's important to have data like this, because sometimes when you raise topics and issues around racial differences, ethnic, changes, same-sex parents, things like that, and you're talking with administrators, sometimes there's kind of a, you can run into a pushback or some kind of, lack of prioritization around addressing certain issues. So that's why when you have data that's objective, and you can show, well, this is an issue for our area. There are people who are living here. You can just point to U.S. Census data and other types of things that can show, well, no, this is something that is definitely in our area. And in Florida, it's interesting because there's so many legal sort of changes that are affecting families in Florida. And for same-sex families, definitely this has been very sort of rapid evolvement over time, just in the last several years. So it's just important to kind of just mention, what's the status, what's going on with same-sex families. Well, in 2010, the 3rd District Court of Appeals, the 3-judge panel there, they unanimously agreed with the Miami judge that there's no rational basis to prohibit gay parents from adopting, because it had been on the Florida statutes, this is a ban against same-sex parents, and it was struck down in 2010. And then this article, this nice article that's listed here that was published in January 3rd, 2015, just a few months ago, really talked about how this rolled out and how this has been affecting families. But the issue with the 2010, so the 2010 District Court of Appeals decision struck down the ban, but that meant that individuals could become parents but not adopt jointly. So there was still a wrinkle in the law and some challenges there. And parents, same-sex parents, had to go through this sort of legal process and pay lawyers, and it's just very cumbersome, timely procedures that were put in place even after that decision. And then now, just a few months ago, you may have heard that same-sex marriages are now happening statewide in Florida, and that was based on the Court of Appeals ruling and the Supreme Court, not weighing in on this, and so it just basically went into effect in Florida. But you would think that, okay, now same-sex parents can get married, and then that would take care of their sort of adoption, related things, because now as a married couple, it's an automatic kind of thing. But the issue is that if they go on a road trip or, get on a flight somewhere to another state that has that ban still in effect, then basically just by crossing over a state border, the sort of definition of their parental rights changes. So that's why this is kind of important to think about, what's going on in Florida, but also what's going on in the rest of the nation because of how families will migrate into and out of Florida. And, the issue on this is from legal conceptual frameworks and data and everything, it's great to kind of have this sort of perspective on the sort of structures of the social structures that are happening and changing in Florida. But really, it's important to think about that there's a lot of different family structures, right? There's single-parent families, there are two-parent families, there's same-sex parent families, there's, lots of different definitions of families, and that this is really, it's at the end of the day for systems of care especially, it's about families, it's about families, it's about families, right? So this is really the drive of this, that this is about real people and their real challenges and real experiences on trying to have a good life, living in Florida and in the United States. So let's just take a look at some other data around what's happening in Florida. This is a behavioral health barometer report you may have seen. This is from SAMHSA. And to try to look at what are the major issues within Florida, well, we can see that alcohol abuse is definitely huge among adolescents aged 12 to 17 within Florida, and this is based on a data set that's relatively recent, the most recent available. So we can see this is a major challenge for Florida youth. However, we can see that the number of people who are youth age 12 or older with alcohol dependence or abuse in Florida, you can see this not in treatment, huge percentage here. So even though it's sort of the leading trend and the leading challenge among this population group, we can see that people are just not getting services, and that's why your programs, systems of care, this is why we all need to work together to address these issues. And if we look at illicit drug use, the chart looks very similar, and I'll just kind of go back and forth. You can see alcohol and then illicit use looks very similar. So we're seeing that people are just not getting the services that they need overall. But then if you look at certain racial, ethnic groups, you look at LGBT groups, you look at by gender, you can see these enormous disparities that are even worse, among specific population groups. And there's also data that are available from the CDC, the Youth Risk Behavioral Surveillance System, and one of these is alcohol and other drug use. So that's another data set that you can take a look at. And they have nice breakouts for Florida and compared to the United States. And so you can see the sort of, the issues around this. And a lot of these types of things will go into your needs assessment for your grant proposals. It's, the ongoing data reports that you're using to take advantage of these data sets that are available to make sure that you have the current information for what's happening. And another data set that's available is the Substance Abuse and Mental Health Data Archive. And this is a neat, if you haven't seen this before, this is a really neat web-based application. It's a national census system of annual admissions to substance abuse treatment facilities. And it's got numbers and characteristics of persons admitted to public and private substance abuse treatment programs that receive public funding. This is a huge data set that's available, and it's online, which is great. So you can go to the web, the link here, and you can click on the Analyze Online. Let it do, the web thing do all the work for you. You don't have to do with Excel sheets or data. You can, if you want to delve into it and move it around, look at the data however you like. They have those options available here. But you can also have it run reports for you, which is really nice. So I'm just providing this as an example. And so there's some pull down, how to line up your rows and columns. So in the row side of it, we're going to have, for example, we're going to select race. And then you can also look at it by the U.S. Census codes to run, what does the data look like for your area. So I just kind of pulled it out for what does Florida look like overall, and these are by the racial ethnic categories according to the U.S. Census. And if we look at how these fall out in terms of the pie chart distribution, you can see on the left that this is the Florida annual admissions to substance abuse treatment facilities. And if you look at the sort of overall representation of, well, what do these racial ethnic groups look like, in Florida overall, you can actually see that it's really similar. When you look at these charts, they look very similar, and we can see differences among minority groups, certainly. Asians, for example, are very minimally represented in terms of admissions to substance abuse treatment facilities compared to their percentage of the sort of Florida overall. But when we do this sort of back and forth, when we look at disproportionalities, particularly, it's important to make these comparisons and say, well, okay, well, how are they sort of represented in the overall population for our service region, our county, our state, and then how do the data line up, in comparison to that? So, so that's the sort of Florida overall, right? It looks very similar. Like, we don't really have, from at a glance, it doesn't look like there are many, enormous disparities, by pie chart, areas here. But if we look at specific groups, when we start sort of zeroing in on specific locations, and for example, this is Punta Gorda. I just pulled out this sort of sub-data set on metropolitan statistical areas. This is the Florida data for annual admissions to substance abuse treatment facilities for this specific region in Florida, Punta Gorda MSA. And then if you look at the sort of U.S. Census, well, how do the people, are they represented in Punta Gorda overall? You start to see now these differences, right? So you can see, for example, that blacks and African Americans are 12.5% of Florida annual admissions in this region for Punta Gorda. However, they only represent 6% of the population, right? So these are the types of things where you go, oh, aha, okay, now we're seeing some differences, and then you can use this data to have these sort of follow-up conversations. Well, why is this, and what's going on? And that's sort of the whole point of this, is to use data to then drive, the next steps. And there are definite considerations. It's of course important to remark that any data set, you have to kind of look at it, is it a disparity or is it a disproportionality that we're looking at when we look at these differences and how people are being represented, or underrepresented or even overrepresented in different services. And then, sample size considerations, the matching of variables, the sort of data collection, timing, and the methods. Excuse me, from one data set to another, there's, you have to kind of critically analyze how did they get the data, and, how good is it, things like that. But the whole great point of it is to then have these actions. Okay, now we have something, objective that we've got in our hands that we can then use for service planning. We can show that, for example, if we are not engaging population groups, in accordance to their representation in our local, service catchment area, then what do we need to do better outreach to them? If it's, minimal numbers of Hispanics, for example, are being served by a substance abuse mental health system versus an overall large percentage of Hispanics in a certain region, well, that would mean that maybe there's something going on here. Maybe we need to, make sure that we have interpreters, and bilingual staff. We need to have materials that are in Spanish language. We need to work with community groups to identify, well, what's going on here? Like, why are people not engaging in these services? So that's the exciting part about trying to use the data to then make those sort of action steps, to hold community meetings and stakeholder work groups, to identify and overcome barriers to treatment. Maybe it's stigma, maybe it's perceptions, cultural perceptions, or whatever the issues are. That's so important to then kind of operationalize or move into that stage of what can we do to make sure that our services are more engaging and welcoming to different population groups, to then internally examine cultural linguistic competence among staff. Do they have cultural linguistic competence to a level that they feel comfortable to engage in, to do outreach to different population groups, to be able to engage in, different groups into services. So this is an ongoing conversation. It's an ongoing sort of evolution of professional services within systems of care, and look at those policies and procedures and frontline practices. So we're going to talk a little bit more into detail about this as we move this forward. And the whole point of this is to really get a sense of the big picture, because that's what these behavioral health disparities impact statements are really for. I mean, there's an approach that can be taken to where, well, we're going to do the sort of minimum basic expectation of, sort of checking off the box and meeting this requirement. And that's one way that some, some grantees will approach this, but that's really not the model. We want to aim for the model. We want to go to that next stage. In a lot of systems of care, especially, they're light years ahead. They've been doing this for 5, 10 years. They've got, materials in 20 different languages or more. They've got, staff that are well trained. They've got certifications. They've got, all these wonderful things that are in place. Well, by not sort of aiming for the model, the challenge is that when you're applying competitively for these grant opportunities, you want to not be behind the curve. You want to really be leading the curve in the model. So that's why we're kind of approaching it from a system standpoint in a way that you can see where we can go with this. And because this is the opportunity, this behavioral health disparities impact statement requirement now, it's a fantastic opportunity to address these issues that have been neglected or have not been able to be addressed from a professional sort of structural standpoint. So this is a tool or a mechanism to be able to address these things. So when we look at a systems perspective around the child system versus the adult service system, these sort of publicly funded, federally, state, and locally funded human services systems, we can see that from birth to death, from child to adult systems, there's this age range in between, right? And this is where there's a lot of drop-off or fall-off, where there's an aging out, or there's people don't qualify for services as much, or they're not designed, for the transition age population. And so these youth, like in foster care and, and all these other systems, child welfare, juvenile justice, et cetera, child mental health, they are unprepared for adulthood in many ways because they have had developmental or social, emotional, behavioral delays in their development. So what they will do, and we see this over and over from the literature, it's all connected, because you'll see, juvenile justice leads very strongly into criminal justice, and child welfare and juvenile, all these sort of challenges that they have with these service systems and the child serving system, they lead to all of these sort of adult-related challenges. So by having a systems perspective, we're looking across all these different service systems, which are, let's face it, there's a lot of silos between these structures. So we really kind of need to think, how to bridge the gaps between these different structures. And it also involves refining organizational approaches. A lot of times, from working in a lot of TA and working with agencies, and there are some really well-meaning service practitioners. But unfortunately, a lot of times what we find is that there's a lot of attribution to individual risk. Like, those youth, are having these challenges because of these specific circumstances. And it's a client-focused perspective, which is good. But if you place the risk, the caution here is that by putting the risk on the individual, it means that the individual is the one with the problem, right? And we're kind of not considering the social structures that are surrounding them because of, the challenges they may experience because of their race, ethnicity, gender, sexual orientation. Depending on where you are in a sort of affirming or welcoming environment versus a rejecting environment, that can have enormous differences in their outcomes. So it's not necessarily the individual risks, it's also social, the larger risks that are surrounding them as well. And so this behavioral health disparities impact statement tool, it helps to get that big picture on overall outcomes for children, youth, and families within that larger system of care. And so this is about kind of changing perspectives around the approaches to these issues. And there's a ton of rationales that are why this is important, why is diversity inclusion important, why is cultural linguistic competence important, why is it important to have a behavioral health disparities impact statement that looks at the challenges among different population groups. Tawara Good and her colleagues, Dunn and Bronheim, they've had a seminal article that was published and really listed out some great rationales. And these are talking points for you when you're addressing things with administrators, when you're discussing the sort of reason why it's important to do these things, because it can improve overall quality and efficiency of care, certainly health and well-being outcomes, so the quality of life for clients, can improve communication and trust between the youth and family and their provider, increasing provider knowledge and skills, and then also increasing, of course, client satisfaction, youth, family, and provider satisfaction. And then if you look at it from the sort of reduction of negatives, then it can yield declines in medical and mental health disparities, provider bias and discrimination, delays in seeking needed care and services. And that's a big one, because if people don't feel welcome, if they go into a service, the agency, and they don't get a good feeling, from the front desk person, or they're, people are feeling rushed, or, people are pushing paperwork at them for, here, fill out these 15 forms, or your intake, or, whatever. I mean, I don't know if you've ever been to a clinic before, or using like a medical facility, but, I think a lot of us have had this experience where it's just not exactly a warm and friendly place. Well, they're not going to, why would they want to come back, and they're vulnerable populations that have real deep-end needs. So, it's important to have this sort of cultural linguistic competence perspective on, welcoming environments that are attuned to their needs. And then also service system costs, right? It's expensive to have these sort of wastes and delays in care. And this is core. This is why it's important also to address disparities and disproportionalities. Well, it's core to system of care values and principles, which are that these service systems will be family-driven and youth-guided, community-based, and responsive to cultural, racial, ethnic, and linguistic differences. So this is core to what system of care is really all about. So that's the sort of, why it's important, because it's good for people, it's the right thing to do. Well, there's also the money rationale, right, which is also a consideration. It's definitely an important point to raise. It's also increasingly required by federal funding agencies. So SAMHSA is the leading agency on this. They've triggered a system-wide requirement for the grantees to implement or to create and implement a behavioral health disparities impact statement. And this is, systems of care expansion, targeted capacity expansion for HIV, offender reentry program, the homeless portfolio, the suicide prevention, right, all across SAMHSA now. This is not just a system of care, related requirement. It's something that's systems-wide. So it is now a new standard. And this is just a scan, basically an example of a Notice of Grant Award, an NGA that went out that this is, so in the grant, in the proposal, the response for applications to the RFA, it asks the proposal writers for, when they're creating the sort of ideas or the proposals that are submitted to get the funding, you got to address this behavioral health disparities impact statement. What are you going to do? What's your plan? And then that you're agreeing that you're going to create one within 60 days, right? And this is part of the I just saw this the other day on the system of care expansion and sustainability. 60 days, so 2 months out of the gate, you got to have your behavioral health disparities impact statement ready to roll and submit to your government project officer, your GPO. So this is something that, is following right along from the requirements for when the funding first initiates, and then to the notice of grant award. So after you've been awarded, congratulations, you've been awarded this funding to implement system of care or whatever it is under SAMHSA. Now here are the conditions, right? And this is a scanned copy of an outline that says, by a certain date or whatever, you must submit, right, the behavioral health disparities impact statement on how you'll address race, ethnicity, and LGBT status in terms of your data collection. How are you going to look at your data in this way? How are you going to do your reporting, things like that? And then what's your plan? So you're going to, maybe detect what's going on among these different populations, that some are doing better than others, right? So what is the plan? How are you going to implement, the alignment of your services to address those challenges these populations are having? And the framework is the class standards, that you'll use the class standards to structure those activities. And class standards, if you're not familiar with the class standards, they're the culturally and linguistically appropriate service standards. And that's sort of a whole other presentation. But I'm going to briefly just go through that in just a moment, of sort of the components of what the class standards are. So I just wanted to send a quick poll out, now that you've kind of heard me talking for a little while now, and I wanted to implement just a quick poll, if you could, to indicate whether you have a behavioral health disparities impact statement or not. So if you could just click, and we'll just spend a few moments and see how these numbers tally up. Okay, so it looks like they're stabilizing about half and half. Interesting. So yeah, okay. So they're changing a little more. We have a sort of live updates on the webinar, so they're kind of populating as they're being entered. So it's about 2/3 do not who are on the call, and 1/3 do have one in place. So that's interesting to show the differences. So we'll just move to the next slide. So the next question is, could you generate reports by race? Like if you were asked tomorrow we need a report on your services that are utilized by your clients, can you generate a report by race? Okay. And the majority can. So race is more of a standard demographic that can be pulled. But I am seeing no's in here, so that's interesting also, just to show, that's a core demographic now, and it has been for a while. So it's important to be able to, if you were asked tomorrow to provide percentage, what's the percentage of clients that you have? How many, total number versus, the number that you have available, the number who are by race, divided by the total clients. Can you provide, reports from that? So it's important to be able to articulate and be able to generate these reports as they're needed. So let's move to the next one. We just have a few of these. How about ethnicity? Someone's ethnicity, would you be able to generate a good report that shows those percentages? Okay. So the majority is by ethnicity as well, and a few have said that they would not be able to generate that report. So those are interesting responses. And so now let's move to the next. So let's do gender. Okay. Would you be able to run a report, that would analyze the gender? What do services look like between boys and girls and young men and women, for example? Wow, okay, so everybody's got a gender part of it. That's very interesting to see these differences. Wow, okay. And then now let's move to the last poll question. So what about sexual orientation? Would you be able to generate a report that says, we know that we have X percentage of gay, lesbian, bisexual, or transgender youth, for example? Yeah, and this is interesting too, because this is definitely sort of a newer variable or newer demographic to be added to different intake forms, and it has to now that SAMHSA is requiring to be able to look at and report on and address disparities by race, gender, race, ethnicity, gender, and sexual orientation. You can see now the gaps that are between these groups. So that's kind of why we did this polling to kind of a spot check on where everybody is at with their ability to generate those reports. Very interesting. So how do you get started? Wow. Well, I mean, the purpose of behavioral health disparities impact statement, we've discussed the rationales and why it's important, and the diversity of the population is changing. But the core purpose of it is to assess and heighten the impact of policies, programs, processes, and resource decisions to reduce and eliminate behavioral health disparities. That's its core purpose. But we know, as we talked about, there's data that are isolated in agency silos, maybe for a specific report or, to address a certain policy or something like that, but they're not really connected. And data are ideally gathered on disparities and disproportionalities to address those differences in what SAMHSA frames as access, service use, and outcomes. So these are the three sort of top general areas of investigation of where you would look for disparities and disproportionalities. So the questions that are associated with these for access, for example, are who are the subpopulations, these specific groups of people by race, ethnicity, gender, LGBT, that are enrolled in our programs, right? Do they have access? Is the front door open to them? And if you're not able to have data or reports or an ability to sort of track that, then it's kind of unknown. I mean, it's sort of informally understood, but now we're moving to a formal stage with the use of behavioral health disparities impact statements. And then service use, what populations get what kinds of services? So how are they utilizing services? Are they, are people of certain races, ethnicities, for example, utilizing services in different intensities than other groups? And then by outcomes, that given the specified outcomes of the program, right, the program is intended to, to reduce alcohol, substance abuse dependence, for example. How do these vary by subpopulations? So are there differences by race, gender, ethnicity, LGBT, for example? So how do the outcomes look different among these populations? So those are the three major categories where, to address access, service use, and outcomes. And again, this sort of drives your CQI strategies. What are we going to do about these differences that we've detected, these CQI strategies, continuous quality improvement strategies? And, we talked about you having the data that's available, for example, U.S. Census and your service data, even training data that you might have for that are being given to your practitioners or for your system of care. The training data are important too. In Mississippi, for example, we have an evaluation form that is provided that asks participants to indicate their race, ethnicity, gender, sexual orientation, right, age, and who are the people who are in the training, what are their characteristics, and then we ask them about their commitment to cultural linguistic competence and things like that before versus after the training. And it's very interesting because you can look at what are the differences among these population groups. So even your training data can indicate there might be a need even among the professional workforce connected to systems of care. We really need to kind of address some of these issues. And also collaborating with community partners, youth, of course, families and community leaders, absolutely, and wraparound agencies to gather local data, right? So definitely, asking for help, reaching out, connecting to other service systems and saying, oh, do you have a report on, this by race, ethnicity, gender, et cetera, asking those questions to get that bigger picture. and then comparing with that aggregate national data, so for example from the Department of Health and Human Services. And this can help to identify the needs of the community, the gaps and services, whether services are client-centered, meaning youth-guided and family-driven, whether services are culturally and linguistically competent or aligned with the class standards. And so class standards, we've kind of mentioned class standards several times. This is the sort of snapshot of the report that's available from the U.S. Office of Minority Health, listed in blue here on the right. And the class standards are intended to advance health equity, improve quality, and help to eliminate healthcare disparities by establishing a blueprint for health and healthcare organizations. That's its purpose. It's a set of standards for how organizations can address cultural and linguistic appropriate services. And the principal standard, the core standard from this is like standard number 1 out of 15, is to provide effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and communication needs. I mean, this is another driving mechanism of addressing disparities, disproportionalities, and the need for cultural linguistic competence from a professional standpoint, a structural standpoint, at organizational level. And here are the standards listed here. Again, this is sort of another topic that is, there are webinars that are available that are incredible that have been done from technical assistance providers. It's kind of its own discussion. It has a lot of depth to it and a lot of richness. But here's the link here at the bottom of this slide. If you want to look at that or look up the class standards on a Google search, and it'll come right up to learn more about some of the details around those. So here's an example of the framing of, how do we set up a behavioral health disparities impact statement? Well, here's an example of how this was done for a system of care community, where we basically broke it out into 2 different parts. Part 1 was about sort of a background. What's the big picture for our population of focus? As Kathy mentioned, what do we know about our population of focus? What are the data? What are the statistics? The issues around their needs. And a lot of this is from the needs assessment or the statement of the problem or statement of the need from your grant application. You might have, a lot of this that's already been done where you lined up, what are the challenges among this population. So the statistics for your state, your region, what's the big picture? Statistics on the program service area by county and zip code. You want to kind of zoom in, as much as possible on the specific population of focus by age and condition and, diagnosis and, these things that they're experiencing. And then also the look by, by race, ethnicity, LGBT, are the data broken out? Are we able to look at those differences? And so you're kind of using secondary sources, from other places where they already kind of, gathered it and put it into a nice report. But a lot of times they won't disaggregate, or have it by these different population groups. Some do, some don't. So it's, it's just kind of, it's a scan of what's available. And then the impact statement, excuse me, part 2, is really where the rubber meets the road, right? It's where you've got specific information regarding those subpopulations, like those different population groups that you're planning to serve within your program. Your steps for data collection and reporting, how you're going to look at their, the breakout of the disaggregated data reports by race, by ethnicity, by gender, by sexual orientation. And then your plans for developing policies and procedures that will address those challenges that these populations experience. So this is kind of the framework, a model framework. And so this is an example of a program called Infusion. This is in Mississippi. They serve youth and young adults ages 14 to 21 with SED who are transitioning from child mental health services to adult mental health services and or from an institutional setting to the community. This is their specific sort of operationally defined population of focus. And so in the statewide context and needs section, we pulled down all kinds of reports, right, from all these different places. We wanted to understand what are the mental health behavioral difficulties among these youth, what do the treatments look like for them, what about juvenile crime and mental health challenges, their training, what's available for their educational systems, school dropout, things like that. Mental health in the juvenile justice system, where do they get mental health services or not? Teen pregnancy, unemployment, homelessness, all these different topics, because this is all about these systems of care related issues that are touching on the lives of these youth. And again, it's to get that big picture perspective, because if we look at just within little silos, we're not really getting the crossover picture among these systems. And so we started breaking it out. These are the counties of service regions that are being served. We looked at race and ethnicity and the different demographics. So, for example, the Hispanic census population for these counties, you can see that there's 4.3% and 10.7% in one county, all the way up to 13% in one county. So, okay, you've got Hispanic people within this county. At 13%, they are living in the county. Over 10% of the people in the county are Hispanic. But then if you look at the number of Hispanic youth receiving services, so we're seeing this really anemic service engagement level. So that's, part of where it's like, this doesn't make sense. There's some disproportionality issues here in terms of youth or people being underserved. So that raises the question. We're using data to then drive, hey, okay, now we need to find out what's going on and how we can do this, and do better outreach or engagement in the program. And so we did this over and over. We did this for race and ethnicity and compared them side by side, the different racial ethnic groups. We looked, for example, at African American youth in the juvenile justice system, right? And then we looked at all other youth combined. So they're more than twice, in certain counties, there are more than twice than all other youth combined. And that's very telling. So then it just raises the question, okay, what's going on here and what can the program do to address this major issue that we're finding here? And so there's just another example of how we're looking at data. So the access point, in terms of is the front door open, for different groups? Well, SAMHSA now, they want to know, what are the specifics around this? Who are you planning to serve? And this is part of your grant applications. This is part of your behavioral health disparities impact statement. They want you to line up the number of services that are going to be, the number of people who are going to receive certain services. And this is not, in stone or, but this is a structural plan. And so a lot of the disparities impact statements now, we're starting to analyze them at a national level, where we're looking at, the different ones that have been submitted into SAMHSA. We're looking across this and looking at tables like this. And what we're finding is that, unfortunately, some communities just put total zeros for some of these groups, or they're just putting not applicable, right, or unknown, or, it's kind of like, well, what does that mean? So you're not even planning to serve, these, you're not basically saying you're not planning to have inclusive services. So, there's a challenge here that opens up a sort of conversation of, okay, well, why? And so, that's kind of part of this discussion with looking at this. And I'm just going to kind of quickly, I know we're going to the end of our, toward the end of our presentation, and then we'll want to have time for a discussion. But I just want to emphasize a few key points, and then we can kind of close this out to have our open discussion, is that we really want to have those data-driven strategies to improve service performance, right? We want to have regular data reports. We want to have assistance with or a discussion of the data with stakeholders, that community engagement conversation around what are we finding around these disparities and disproportionalities, those specific population-specific strategies to address them, and then having a youth and family-centered feedback loop. And a lot of times in evaluations, and I've been an evaluator now for many years, and it's amazed me that I'm kind of the weird one sometimes when I say, oh, well, where's our direct feedback channel from clients to inform the delivery of services, right, so that we can make improvements and get better. Sometimes it's like that's not a loop. So, there isn't really anything. There aren't focus groups. There isn't a survey. It's kind of like, wow, okay, there's no direct channel from the clients themselves. So it's important to have that direct feedback loop. And so by using the disparities impact statement, that can help to drive, the conversations, not only at a professional level, but also with your community and with your direct clients as well. So one of the first major things is to update your forms. Oh my gosh, it's amazing how much it can take sometimes to update a form. So it's, it's an intake form. It's part of a standard demographics. It's not some weird thing to ask, in a special way and a special thing to ask people about certain questions. And some communities are, they're hesitant about asking LGBT-related questions. Well, that's their own sort of challenge, discomfort, stigma, or a need to address inclusion and diversity, because it's a standard. It's a standard to ask people when they, please help us understand the diversity of clients that we serve. This is to help us improve services. We're going to ask you some standard demographic questions, what's your age, race, gender, ethnicity, LGBT. It's just a normal thing. It's not anything weird. So the intake forms need to be updated. And because if they don't exist on paper or anywhere, then it's not going to get into a data system. It's not going to get into your required reporting to SAMHSA. It's going to be out of alignment with the requirement for the behavioral health disparities. It's a standard thing now to have that in place. And that's just how that process goes. And a lot of times, sometimes I'll, I'll run into sort of well, we don't know how to ask the question, or, some kind of interesting responses to when I'm saying you need to change your form. Well, for race, ethnicity, here are some examples, from the U.S. Census, right? These are the ways to ask this question. For gender, a lot of times you'll have male and female already on your form. Well, people who are transgender, they don't exist, on a form like that. So you can either add transgender male and transgender female, or just have male, female, transgender. Not a big deal to just modify that question a little bit. And this is one you may have to add. A lot of you mentioned that you're not able to generate a report, by LGBT. Well, this is an example of a question. Which of the following options best describes how you identify your sexual orientation? And here it is. And that's it. It's not some weird thing. It's not discomfort. It's not, well, they wouldn't want to answer that. They think it's personal. I've heard all kinds of different things about sort of why we aren't able to ask this question. Well, it just doesn't make sense. It's a standard now. So it's just how it is. And maybe training needs to be done with staff and supports. There need to be meetings or discussions. But, at some point at the end of the day, the forms need to get updated and the data need to get collected. And it's how the process is done in a warm and friendly and welcoming way is important as well to think about. And the second major point I just want to raise is to have an anti-discrimination policy review for your organization. So if you're an ally of different races, different ethnicities, people who are gay, lesbian, bisexual, transgender, you believe in equality between genders, right? And you want to sort of look at and examine and put action steps forward to address disparities and challenges and disproportionalities that these groups might experience, you may certainly run into some pushback because people aren't used to it, or for whatever reason. There's biases, there's institutional discrimination. There might be just any kinds of reasons, administrative bureaucracy, whatever the issues are about it not being a priority. So having an anti-discrimination policy review that's inclusive, this is important because it's that first line of defense to empower staff who might be afraid. They don't want to say something at a meeting. They don't want to stand out. They don't want to stand up for this because they're going to be seen as whatever, I don't know, some challenges of not wanting to be the one to say this or whatever because they might fear repercussions. right, or going against the grain, or whatever the issues are. Well, by having an anti-discrimination policy that's in place at your organization that's inclusive, and it's inclusive by race, ethnicity, gender, sexual orientation, gender identity, this is the protection for, for staff to be empowered to, to do really what systems of care are designed to do anyways, is to have inclusive services. But, you want to have these policies in place because it does protect those employees. So not only is it in the employee policy, but it's also your partner agencies. So if you're doing referrals to other systems of care, let's say you don't do homeless services, but the youth you're serving have mental health challenges and they need housing, or whatever the sort of other systems of services that they might need, why would you refer in? They might be very well welcomed and have a wonderful inclusive engagement with your staff and great services within the walls of your organization. But why would you refer out to another agency where they might have all these biases and challenges, right, serving your youth? So why would you want to put your youth at risk, to then send them over to a place that has, you don't know if they have protections that are in place? So it's important that, to actually kind of do a little homework and see, well, is that a welcoming place, for gender, race, ethnicity, LGBT? Is it real? Is this somebody that we want to have a good relationship, organization to organization, system of care relationship with? And then your vendor contracts, right, for the services that you might contract out to do, having it as a standard clause in there, we do not discriminate by race, ethnicity, gender, sexual, things like that. So that's important to have that structurally. So this is a quick poll, and I know we're going to run into the end of this and make sure that we've got our point for conversation. But if you could just click have you done a review of your employment policies? An actual review of, you've looked at it and you can specifically specify, we know what's in our employment policy that is protecting specific groups. Yeah, so many people, it looks like about half, as it's totaling up, have not. A lot of times employment policies, they're kind of like the taken for granted thing. They're in some kind of manual that's collecting dust on a shelf somewhere, or maybe it's on a file on a shared drive, or, oh, we got an employment policy, but I don't know where that was at orientation, like when I was hired, 10 years ago or something. So employment policies, though, are that's what happens to rely on when there's something at issue, right? When there's a challenge, then it's like, okay, what does the policy say? Oh, the policy's inclusive, and we're protected when we do these things. So that's in place. So, and then to expand safe zones and safe spaces for the clients that you serve. Safe zone is a great model for designating certain areas like meeting rooms, common areas, on your office door, or wherever, to signify that it's a safe zone, that there are allies that are in place, to address disparities, disproportionalities. And there's tons of examples. Lots of them are very colorful. A lot of universities have safe zone programs. There's rainbows, there's triangles, there's all kinds of colors and wonderful things. There's sort of caution signs and things like that. The system of care one is on the top left there underneath the purple text. That's the actual SAMHSA system of care, rainbow that's showing that it's inclusive. So that might be just something that you want to have to signify. And if you're not into symbols and colors or whatever it is, you can have just a simple sign that says it's a safe zone. And this is in the top right-hand corner. This space respects all aspects of people, including race, ethnicity, gender expression, sexual orientation, socioeconomic background, age, religion, and ability. Wow, that is a safe place. That's a place I want to be, and that's where I want my friends to be. I want to have a nice, safe place where people can have services. And this is an example of a sign that was put up on the front door. This is in Mississippi from one of the system of care projects that I'm working with, the Mississippi Transitional Outreach Program. And they have the safe zone, right, the statement with the symbol there, And then they also have it in Spanish as well. So this can be done. This is a way to put it, in the conference room or whatever, if you don't want it on your front door or whatever. You can have it on the hallway walking in. You can have it at the reception desk. You can have it in the conference room, the youth group room, wherever it happens to be, to signify this is a safe place. And then to have training opportunities, and there's a list here that's available for you. I'm just going to run through to share learning content from specific trainings around disparities, disproportionalities. We talked about having inclusive referrals, partnering with community alliances, and it's important to have success stories because a lot of times, human services, there's a lot of focus on challenges and, a lot of, the needs and the sort of, challenges that we run into. But to actually celebrate those success stories that are inclusive, how did we address disparities for this population by, these African-American youth, this Hispanic youth, these LGBT youth? How did we make it so that, we overcame challenges to address a disparity or a disproportionality? That's a powerful story to tell, and that's something that we really want to have. Self-assessment tools, we talked about how maybe some staff might have stigma or some discomfort. Let's detect that, and let's address that. I mean, that's something that is a sort of way to provide inclusive quality services. So having self-assessment tools. You could do asset mapping, train-the-trainer resources are out there, connecting with other systems of care that are doing great work and have inclusive services, social marketing activities. So that's the end of the sort of content portion here, and I'll hand it back to Kathy to discuss the next steps for additional calls.
Okay, well, we wanted also to, thank you, Peter, very much. A lot of information we know. So what we wanted to do was invite you, and we still have 15 minutes to talk some more about this and answer any of your questions. So we're going to open up the line. What we wanted to do is we do have a monthly call. The TA Network hosts a monthly call with the cultural and linguistic competence coordinators from across the country. And the last, I'd say, 2 or 3 calls that we've had really have focused on the behavioral health disparity impact statements. A lot of it about how to collect specific information, where to get the information, how to write it into some evaluation parts of your program, and a lot of it around the LGBT piece. But the calls, we actually have a call scheduled for tomorrow that Dr. Peter Gamache leads, as well as Miriam Monsalve-Sena and a couple of other people and different CLC coordinators are on that call, sharing their challenges that they're having, some of the things that have worked for them. So we're inviting you to join this call if you'd like tomorrow. It's these are the dates of the future calls, and they're not always about behavioral health disparity impact statements, but tomorrow's call is. So if there are, if after you finish this presentation, you go back and talk to some of your colleagues about it and have other questions, we invite you to join us on this call tomorrow from just an hour call, and it's just an open call. There's no PowerPoint or anything else, just a telephone call. So we'd like to go ahead and also have Dr. Cosima Boston say a few words in terms of the state expansion and the efforts of the CLC committee, if you would like to, Dr. Boston, and as well any other comments or questions. There's a lively discussion in the chat box as well. So
all guests have been unmuted.
So any of you, please feel free to join in the conversation.
Sure, Kathy and Dr. Gamache, I want to first say thank you so much for delivering this very informative webinar. I think it helps, I know at least myself, and I'm sure others, to really begin to think about this behavioral health disparities impact statement in terms of, how are we going to get ours created. We have in Florida, and everybody knows, we have existing SOC sites, we have graduated SOC sites, we have new SOC sites, and we have expansion sites. And the 5 that I'm working with, expansion sites, each of them as part of their CLC initiatives will be developing their behavioral health disparity impact statements. So this was really, really important for us so that we can kind of get a hold on how to go about creating that document. So I want to really thank you for that information, but I wanted to encourage questions from the site coordinators because they each have a different population of focus as you described. And thank you for the terminology because I think that's a really important part of all of this as well. But they all have distinct populations of focus. And so for them, I guess their approach to collecting the data that would go into their behavioral health impact statements would be unique. And I see some of the questions going on the chat are related. I saw some questions related to the transition age group, which is one of the focuses of one of our expansion sites. So I just wanted to encourage those coordinators, if they have any questions, to feel free to either address them in the chat box or share them with us now or at another time. But thank you so much for the webinar.
You're welcome. I did want to say too that some of the questions were around the age group and how comfortable some of the youth felt in terms of disclosing either their sexual orientation or their gender identity as they got older, and that it was something that they were more comfortable doing as they got older. And I know that we had a discussion on this call on one of the CLC coordinator calls about collecting that particular data. And I don't know, or if anybody on the call, Miriam, or anybody that has been collecting that data has any thoughts about that.
Yeah, and that's a real, that's a real point of reflection too, because a lot of times we, we'll hear, oh, well, we work with, high school teens, or where they're more comfortable asking questions about sexual orientation in particular than sort of younger age children. And we've been asked about, is there sort of an age cutoff or a certain, point? And when we look at the research literature, I mean, because of social acceptance, because of a lot of different trends that we're seeing, youth are basically coming out earlier and earlier ages into middle school, which is amazing to me. I mean, I never thought that growing up that, high school was kind of a stretch. Usually a lot of people would wait till after high school or whatever, but into middle school, and so these younger age groups are definitely a relevant age group, especially post-puberty and, that age, the adolescent identity integration age. And then you hear stories, prominent stories on national news media, about transgender youth being very young, to and identifying with the opposite sex from which they were born, and their parents are working with medical providers to, to make a decision point around hormone treatment and things like that. So, there isn't really a fixed age or any kind of, exact cutoff point or anything. I just think it's, it's just kind of like, and by asking someone about their sexual orientation, the assumption is that you're asking them if they're gay or if they're lesbian. Well, that's not true, because they can identify as heterosexual. It's just an option. So when you have a question to say, well, how do you, that example that I had shown, how do you best describe yourself? Well, they can indicate heterosexual, unknown, gay, lesbian, whatever they want, and it's just an option, And the other consideration point as well, some people will think that that's, sort of intrusive or too private. But when I hear that, it's interesting that, sexual orientation and gender identity is seen as like a too private kind of way of, getting to a certain, information. But then a lot of systems of care, especially with mental health and substance abuse, you're asking about everything under the sun: sexual abuse, mental health, prescription opioid, abuse, illicit drug use, juvenile justice. all these different challenges, these sort of personal related, suicide ideology, and these are critically sensitive personal questions, but somehow you can ask about those issues, but not sexual orientation. It's kind of like, what's the challenge here? Is it your own discomfort, or is it an assumption that it's theirs, or what? And so that just kind of opens the conversation of, well, how is this being approached? Is it just a normal standard thing, or is it some kind of special, strange, approach?
I think this is. I'm sorry. Go ahead.
Go ahead.
This is Dr. Boston. I just had a quick question, and that was about your, Dr. Gamache, your long-term and intermediate points. I mean, long-term and short-term points. And the quick question is that were you suggesting that these may be places to start in terms of collecting information for our behavioral health disparities impact statement?
Yeah, those are like steps for action steps that could be taken to to get the ball rolling. Certainly, the first short-term step is always change. Make it so that your forms are inclusive, because from a data standpoint, if they don't exist on paper, they don't exist there's no analysis that can be done. And from a quality improvement standpoint, we always say, you can't improve what you don't measure. So if you're not measuring it, then it's not seen as important. So the forms are the number one thing, and then the policy review on employment policy is critically important, because it basically enables the individuals who are allies to be able to address those things.
Thank you.
I think this is. I think what we found was that this is Kathy. What we found with some sites was that they didn't have the data available, so they were at the stage where they needed to figure out how to even start to collect the data. So that's why one of the first things you want to do is take a look at your forms to see, are you actually collecting the data that SAMHSA is now requiring you to have. Any other questions or comments or that you'd like to ask at this point?
Yes, I have a question, excuse me, or a comment. This is Evelyn, and I work with the transitional youth. I'm curious, because I did notice this, because we do report on that for our culture and stuff. Would it be possible to maybe develop a survey monkey for the kids? Because I think when it's anonymous, they really open up. We have found that once they turn a certain age, they have no problem talking about, let me just put it that way, a lesser problem talking about the sexual orientation, and many of them are now calling themselves androgynous when we go to ask them, so that they are not identified or placed in a certain category. So I'm thinking maybe something that is completely anonymous, like perhaps SurveyMonkey, might help.
Yeah, the method is what's most appropriate for them, and I would run that by validate it with their perspective. So,
Okay.
if you have a community advisory board, or run that idea by them and say, would this be, do you think this would be a good idea, and have that input. Absolutely, I think that's great.
And I know that I've sent up a couple of evaluation forms, or the evaluations that we do, the IPP, to Dr. Boston, and I've noticed that the kids are like, we don't want to be categorized. So I'll put that in quotes, but they say you can report on it, and it's ironic because these kids are pretty smart at this age, and they're like, we know you have to report on it. We just want it put in quotes that we don't want to be categorized, which I found very fascinating.
Yeah.
Hi, this is Loren Joseph. One of the things, I'm in Orlando, one of the things that I've noticed over time is a part of the challenge is that a lot of times information is being collected very early in the process, and when trust has not yet been built. And so sometimes the challenges that present themselves are how people view assessment as this finite process that begins early and is never revisited. Because when trust is developed, the youth are much more willing to disclose because they feel safe. So I think it's important to have different opportunities to gather that information over time, because that information does shift based on who is collecting the information and whether or not the individuals feel safe.
Oh, I totally agree. Absolutely. Yeah, and it's.
I think I'm going to say too, Loren, I think that's absolutely true too, and it's so noticeable when the youth starts to feel safe, because what happens, we've seen in agencies too, is that staff don't even feel safe in some of their agencies because they're worried about the consequence. So
exactly.
What happens if they themselves disclose, you know? So it's not just the youth and maybe even parents or same-sex parents of the youth, but it's also staff. So
definitely.
Yeah. And I just wanted to mention, so the time for the learning exchange calls, I know this says 2 to 3 p.m., but I think, Kathy, I've got the time as 1 to 2 p.m. EST. And it was in the TA telegram.
I'm sorry, is it 1 to 2?
Yeah, because I just wanted to check that, because I saw it in the TA telegram, and I've had it recorded as 1 to 2 p.m. EST.
1 to 2.
It is 1 to 2.
Okay.
It is 1 to 2, so that slide is wrong. It is. We're so sorry. So that slide, the exchange calls, the peer-to-peer learning exchange call tomorrow, it's from 1 to 2 p.m. Eastern Standard Time.
Okay.
So sorry about that.
Well, we're really looking forward to it if you're able to join, and this was such a great session. And if there's any additional follow-up questions, please feel free to connect with us.
Yeah. Okay, so we're in respect to all your time. It's 2:30. Thank you all for joining. And again, please feel free to join us on the call tomorrow from 1 to 2 p.m. Eastern Standard Time. And the call-in number is on this slide. You can also download the slides from the box there where it says updated Florida expansion behavioral slides. So thank you all, and we'll talk to you again.
Okay, bye-bye.
Bye-bye. Thank you.
Thank you.
All guests have been muted.